Okay, I'm sure we still have like a few people hopping on, just starting their lunch hour. But hey everyone, welcome. Today is our final Wellness Week event, so we're super excited if you're on today. I'm Katie Hills. I do the marketing and communications at BBB Cleveland, along with Pam, who's also on here. Today, we are very excited to welcome Dr. Fiffick. Since August is National Wellness Month, we wanted to explore some of our different accredited businesses in the health and wellness space. And so today, we're honored to have Dr. Alexa Fiffick of Concierge Medicine of Westlake. She specializes in women's health and will cover topics such as women's health issues in the workplace, policies to support women, and how to support yourself and your coworkers. If you guys have any questions during this webinar, you can put them in the chat and Pam and I will look at them at the end and we'll be able to ask Dr. Fiffick. Take it away.
Thank you so much, Katie, and thank you for having me. I'm going to take over and hopefully everyone can see my slides. Yes?
Yep, we're all good.
Perfect. Awesome. Because I can't see any of you or the chat, so you'll have to shout at me. Hi, everyone. I'm Dr. Alexa Fiffick. I am a board certified family doctor and a fellowship trained menopause expert. As of September 5th, 2023, I have been in private practice at Concierge Medicine of Westlake, where we offer both primary care and specialty women's health services without the interference of insurance. So it really is one of my very big passions to talk about how we can change things for women in healthcare, in the workplace, in pretty much every facet of life. So I'm really excited to have this chat today with you and the rest of the Cleveland BBB. A couple other things about me, just to clarify my training a little bit more. I also, because of my fellowship training, am a Menopause Society certified clinician, as well as I act for as the Associate Director of Education for a national company called Womeninmedicine that focuses on women's health clinicians, and have been working as a menopause expert for Menopause Mandate US, which is a branch of menopause mandate that came out of the UK, whose main focus is on improving women's experience with menopause and the workforce. So I'm going to get started talking a little bit about specifically that. Women make up currently about 50.4% of the US population, depending on which statistic you're eyeballing at the time. And ironically, they make 50.04% of the US workforce. Out of that portion, 30% of the total US workforce is women that are in the midlife stage and is projected to be the largest growing workforce cohort in America in the very, very near future. And taking a look at kind of where women have been historically located, we all know that it took some time for women to get into professional degree training programs, as well as many other career paths. 52% of law degree recipients, so the majority of people going to law school are women, but still only make up 39.5% of lawyers. Is that women make up about a little over half of the population in both society and the workforce. And women in midlife, or women in their 40s, 50s, 60s, are really the largest growing subset of the American workforce. About half, or a little more than half, of all of the degree receivers for law schools, dental schools, medical schools are women. However, a significantly less than half percentage is what is out in the workforce currently. So part of that has to do with the fact that we're playing catch up of getting clinicians and legal experts out into practicing to make up, a chunk of the population. And the other problem is about a lot of the things that I'm going to talk about in a little bit. But one of the ones that I think is really, really prevalent for us here talking, during BBB Wellness Week is that 39% of all US business owners are women, but that number is still only 9.2% of the workforce. So we are still working really hard to be present in a lot of the places that make a difference, whether that's in healthcare, in policy, in law, in making up the businesses that you go to and get services and goods from. We're still a really low portion of what is out there. So I think a lot of that has to do with the fact that we're playing that catch up of training people to go out into the workforce, or getting people motivated to go start a business, but we really don't have the support in order to maintain it. So it really kind of boils down to, in my opinion, us really not having good support for things like family leave, medical leave, and caregiving leave. To clarify, family leave is anything maternity, paternity, adoption, fostering. Not all companies, not every state, and currently not our country has any sort of legal right for these things. Medical leave, whether you are sick, or caregiving leave if your child or your parent or spouse or somebody else has a health issue that you need to be a caregiver for, takes up a lot of time and a lot of energy, and is a still unprotected requirement of many people's roles. The lack of these policies causes about 30% of workers in the private sector to take even a single day in a year that is paid. Um, it often is actually associated fairly highly with missing or postponing medical care for yourself or for family members. It's associated with an increased risk of workers getting other people sick around them because they're showing up to work sick. And it most drastically affects women who are parents and women without college degrees, most likely because women without college degrees are highly likely to have positions in which they are either paid hourly or have some sort of other stipulation to their contract that basically allows them to not have the protection for that leave, as well as providing them any other sort of support systems. Um, Ironically, when we talk about wellness, a lot of things kind of come to mind. And in healthcare, because it's the one that I know, I will use that as an example. A lot of the things that are added to some of the wellness conversations are things that are very much focused on the person putting in more effort in order to be well. And I have a bit of an issue with that fitting the definition, because, yes, I could sit there and say, you need to eat better, you need to do yoga, you need to decompress at the end of your workday. But realistically, if we take a look at what is being pushed out by companies and hospital systems and et cetera for worker wellness, only about 1.9% of those interventions are actually targeting women. And out of those, the large portion of them was really just promoting physical activity. So whether that's, yoga classes or cycling or helping them get a gym membership or something like that, which are great things. I'm not knocking that. It really fails to focus on the parts of women's health that affect them in the workplace. And frankly, I think we could do better. I am a menopause expert, and that is what I spend a lot of my time doing, is perimenopause and menopause, postmenopause. But I work in that kind of in-between space in women's health that kind of falls into everything non-reproductive. And one of the biggest things about the statistics I was throwing at you before is that with midlife women being the largest growing workforce, it is apparent to me that with the baby boomer generation and the Gen X workers, that we're about to see really significant impacts on the workforce due to midlife health changes. Couple studies that I want to talk about in 2023, Mayo Clinic Proceedings released this really big, really great study that basically showed that 13.4% women report at least one, if not more, workplace outcomes as a side effect of some sort of midlife health condition. The more symptoms that the patient has, the more likely they are to have adverse outcomes. Those adverse outcomes can be anything from absence to decreased productivity to being late frequently, although they're not technically absent. And 11% of women reported missing work within the last 12 months because of symptoms. That accounts for an average loss of 3 workdays per person. When you total that all together, just the work adverse events alone cost $1.8 billion a year due to those missed work days in the US each year. So I kind of call this slide but why do we care? Because $1.8 billion may not seem like a huge number to some people, like it is to me, but women with untreated menopause-related symptoms have an 82% higher healthcare resource utilization. They also have a 57% increase in indirect productivity loss. When you add that all together, those medical expenditures add up to 24.8 billion. So if you're doing the math with the 1.8 of days lost, plus all of the money that your company is probably helping to pay, and those patients are paying because copays are really high a lot of times and deductibles are really high, we're losing about $26 billion every single year by not taking care of women. The more symptoms that patients have from menopause, the less hours they work, the more likely they are to change jobs, turn down promotions, and altogether exit the workforce. A single British study that was done a couple years ago found that if a woman had even one single disruptive menopausal symptom by the time she was 80 or 50 years old, she had a 43% increased chance of leaving work within the next 5 years. That's almost half. That should sound exactly as crazy as I think it is. I talk a lot about menopause, and so apparently to social media, but it can be a really, really confusing topic. So I'm going to break it down a little bit and kind of clarify some things. Menopause itself is when you stop having periods for 12 months and change. You have to get it past that full 12 months and be then not immediately bleeding afterwards in order for us to say that you are fully menopausal. Sometimes it's just potentially due to natural aging. Other times things like surgeries, hysterectomies where we take your tubes and ovaries, or a salpingo oophorectomy is also one of the reasons, as well as other medications that we give patients. Sometimes it's things we give for endometriosis to shut down bleeding and hormone function. Other times it's things like breast cancer treatment, ovarian cancer treatment, colon cancer treatment. And it can be a really, really drastic event for a lot of people. But the focus I kind of want to put here is it's only after the full 12 months of having no periods that you become menopausal. So what is perimenopause then? Perimenopause is everything between when you're having normal monthly cycles in your reproductive years up to the point that you are 12 months and change past having a menstrual cycle. It is, ironically, for a lot of women, a lot worse than actual menopause. That problem is because the hormones, estrogen and progesterone, along with others, are fluctuating all over the place very erratically. So if you've been in the situation where your periods are different and you feel like, oh my gosh, I must be in menopause, chances are it's perimenopause. And it can feel a lot worse than actually being menopausal for many women. Some of those women that feel significantly worse are the ones that have things like menstrual migraines or premenstrual palpitations, premenstrual dysphoric disorder, or clinical PMS, POTS, autoimmune conditions. A lot of things rear their ugly head during perimenopause with these hormonal fluctuations and make it a really, really miserable time for a lot of women. During the early menopausal transition, when you're really in the early phases of perimenopause, your periods aren't that different than they were previously. They might shift a couple days here or there, but it's pretty consistent. So this is often a place where non-menopause clinicians say, oh, well, you're still having, pretty normal periods, like you're not in perimenopause or menopause, versus the late stage where you're kind of skipping some and going a few months in between before they happen. And either side of this coin can be really, really drastic for people. So it's something to make note that is really difficult for people, particularly because menopause literally affects every single organ and tissue in the entire body. One of the things that people know about a lot is that we talk about hot flashes and night sweats being one of the major telltale symptoms, as well as things like increased risk of UTI or vaginal dryness, now coined genitourinary syndrome of menopause. Things like increased loss of hair from the top of your head or increased of hair gain on your face or acne recurring, sort of like a reverse puberty situation that is unpleasant for many. But it really affects just about every single cell and tissue in your body. And it's a very under-respected time in women's lives, that it is a large reason that a lot of women are having major health changes. And I'm going to walk through some of those to explain what I'm talking about. Menopause itself is associated with heart disease and metabolic syndrome. In 2020, for the first time, the American Heart Association was able to basically put out a paper saying, hey, we know we've talked about in the past that early menopause, meaning probably surgical in your 30s or 40s, increases the risk of heart disease long term. In 2020, for the first time, they came out and said, hey, by the way, that definitely does increase the risk of heart disease down the line, but so does just becoming menopausal in and of itself. Some of the reasons that happens is that having less estrogen increases cholesterol levels, increases arterial stiffness, and it increases insulin resistance. Furthermore, we also see increases in the changes to our fat content in our body that are unpleasant. Total abdominal fat, meaning like if you're on social media, the meno belly that everyone talks about, or gain around your midsection, externally is a problem. The bigger problem is that's a sign that you are increasing fat content around your organs like your heart, your liver, your pancreas. And fat acts as a pro-inflammatory tissue, meaning it is stressing all your systems out, increasing the risk of atherosclerosis, increasing blood pressure, increasing type 2 diabetes, fatty liver disease, you name it, it's on this list probably. And so it's something to really, really keep an eye on if these numbers and these conditions start creeping up on you, to talk to your doctor about. Another one that a lot of people do know about but don't necessarily kind of understand the timing with is osteoporosis and fractures. So as you can see here on this graph, estrogen is that blue line, and as it's decreasing, what we see is a pretty significant follow of that black line at the bottom of your bone mineral density going down. FSH is the hormone from your brain that tells the ovaries to do its job and make estrogen. I like to say that it basically is trying to round up a room full of seniors in high school and say, hey, you guys really got to do your work and turn it in. And they keep signaling and lecturing the kids. And they're like, you know what? No, I'm graduating. It's fine. Bye, not doing it. And FSH keeps signaling to do it, but estradiol has left the building. Following that, we see a really significant decrease in bone density within those first couple years immediately past menopause. Ironically, the other thing to really keep an eye on here is at that -1 to the left, you're already seeing decrease in that perimenopause phase that can be really statistically significant. So a lot of people think you have to be 60, 65, 70, 80 years old before bone density really matters. But unfortunately, If you're perimenopausal, menopausal already, you're in the time frame where you're losing bone really rapidly. And if we don't know about it or do anything about it, we probably won't find out until it's too late. Um, it does differentiate a little bit between different race groups. Unfortunately, white women are on average about to lose 2.5% in their back and 1.8% in their femoral neck, or the part of your thigh that meets to become your hip. Um, Chinese women have been shown to be about 2.2 versus Japanese 2.1. And Black women are at about 2.2% in the lumbar spine. So it does differentiate a little bit by race. There's some data that supports having a paler tone of skin or light eyes that also may be associated with an increased risk of rapid bone loss as well. So again, my why should we care slide. There is about $18 billion every single year that we spend on osteoporosis. And a lot of that has to do with, unfortunately, having people hospitalized for things like hip and spinal fracture and needing to end up getting some sort of rod or other device to help put the hip back together with an orthopedic surgery. And so that really shows up with a loss of independence. Osteoporosis and osteopenia show up as about 5 million disability life years just due to hip fractures, which makes up about 40% of those. It increases morbidity and mortality, morbidity meaning death, mortality meaning bad things that happen as a result. And both the 1 to 12-month time frame really rapidly, but also every year after that. It shows that ineffective utilization of treatments that we know can reduce those risks, but maybe we're not optimizing them. And we certainly are often not diagnosing the condition until it's too late. Osteoporosis is often referred to as a silent epidemic or a silent killer because you don't know your bones are too skinny until you break something. And it's current guidelines recommend not getting a bone mineral density test or a DEXA screen until the age of 65 for everyone. Now, that is a across the board if you have no risks and there's no other reason to do it. Recommendation. So often I see patients that do have risk factors or have, God forbid, had a fracture already, not ever get a bone scan because they were under 65. So it's something to definitely advocate for yourself about. Additionally, menopause is associated with cognitive changes. As you can see here on this particular set of images, the age at the time of oophorectomy on the bottom is the age at the time that the patient's ovaries were removed. And I really like this image because it shows pretty statistically significantly, if you look at that far left kind of column for each one, mortality, dementia, cognitive impairment, cardiovascular death, and Parkinsonism have really, really statistically significant hazards ratios when it's at those younger ages. And knowing that, we know that that sort of rapid removal of estrogen producing tissue in the ovary is associated with those things, but it's obvious too across this graph that it occurs even at these older ages. So it's something to keep in mind, particularly if you are younger, to keep an eye out for yourself on this. The recurrent UTIs and sepsis that are associated with menopause. UTIs cost the U.S. about $2 billion a year. About 50% of women are going to have at least one UTI in their life. And the higher burden of UTIs is associated with a recurrence within 6 to 12 months. The reason that that happens is associated with the loss of estrogen. And the reason UTIs matter is not that it's just a simple infection of your bladder and you take some antibiotics and everything's fine. UTIs, especially if recurrent, can cause obstruction of the urinary tract, actual kidney disease or failure, stricturing or scarring of the tubes that connect your bladder and your kidneys. Antibiotic resistance is a really, really big one because at some point we're going to run out of current antibiotics that can kill the bugs that infect us, which is a really big deal. Sepsis, multi-organ failure, kidney failure, and death. So a simple UTI is really not so simple once it becomes recurrent and once it takes kind of threshold in a woman's life. So the reason that that happens is that when you have estrogen in the vaginal and bladder and urethral mucosa or the skin there, it helps to plump those cells up and it helps them keep a nice acidic pH that helps kill off pathogens, viruses, bacteria, yada, yada. When you lose estrogen, it decreases the plumpness or the actual like thickness of the tissue. And so they used to call the term vaginal atrophy or vulvovaginal atrophy when estrogen leaves the building. However, we know now that the same tissue exists in the bladder, the urethra, the vulva, the perineum, all these other places that are down next to the actual vagina, the tube that leads up to the cervix and the uterus, and really all suffer from loss of glycogen, hyaluronic acid, collagen when estrogen leaves. What that leaves us with is a slightly higher pH, more towards basic, that keeps that tissue from fighting off infections very well. Additionally, when those tissues get thinner, it's easier for them to fissure or have little tiny micro tears in it with things like sexual activity, using the restroom and wiping, as well as wearing clothes that might be a little bit abrasive. And so that increased risk of bacteria, viruses, things getting inside that tissue and our decreased ability to fight it off really can show up pretty significantly in urinary symptoms like the UTIs, leakage, as well as anything and everything that is like skin related down below. Additionally, menopause is actually associated with an increased risk of worsening or new onset psychiatric symptoms. One study that I looked at showed about 15.8% of perimenopausal menopausal women with no prior psych condition met diagnostic criteria for a new one. Another one showed that perimenopausal women were twice as likely to develop depression compared to their cohorts. The more negative life events that a woman has, the more likely she is to have a new onset diagnosis of depression in perimenopause. And ironically, this is a point where the data starts to show that perimenopause can be significantly worse than menopause itself, as those hormonal fluctuations are more highly associated with a diagnosis of depression than just when estrogen retires in menopause. So I talked about a lot of really negative sounding things, right? And this brings me back to the wellness portion of it. Yes, I could tell you that you need to meditate and do yoga and, do some wonderful stretching or exercises or eat nutritious meals. But to me, wellness is much more significant. To me, real wellness starts with getting your own healthcare things really kind of up to snuff, getting your PAPs, your mammograms, your colonoscopies, going for your annual checkup to check, am I having, increased risk of atherosclerotic heart disease? Am I developing prediabetes, diabetes? What do I need to do? And I know this next one sounds probably fairly loaded, but sleep hygiene. Sleep hygiene is something that Americans, especially working women, seem to be really, really bad at because it's a time that a lot of women do that revenge procrastination thing where at night all of a sudden you're scrolling all the emails you didn't get through and checking up on social media and this and that and blah, blah, blah. But realistically, women need about 7 to 9 hours per night. Yes, that is more than we recommend for men at the 7 to 8, because we actually do need more. And then there's those other good things: exercising, hydrating, eating your fruits and vegetables, focusing on protein intake. I don't think I've met more than maybe 1 or 2 women in my entire career so far that at least meet, if not exceed the amount of protein that we need per day. Pro tip, it's about 80 to 100 grams per kilogram of body weight or pound of body weight. So it is pretty significant compared to what normal women have been taught to eat in the 80s and 90s, where we told everyone to eat salad and not chicken or fish. And other things that are really, really hard for women to do: scheduling time to socialize outside of the obligations. No, I am not counting your 5-year-old's birthday party where you went and talked to some other mom for 5 minutes. And no, I'm not talking about you going to some mandatory work happy hour. Actual socializing that is built for just that and no other benefit. Continuing to engage in your own hobbies. Again, I'm aware this sounds totally loaded for a mom who's working, who's got 3 kids at home, who is gonna, try her best to go back to running in the park. But realistically, every time one of the kids has the sniffles, you're not going. I get that. And so my ask is that one of the places that we start for ourselves is really focusing on at least the bare minimum of getting your annual wellness and cancer risk assessment and cancer screening things done, and starting to say no to unpaid labor. Oh, and I got cut off somewhere there. I know it's a thing that women need to work on a lot, is when you're being asked to take on other roles at your job, saying, I have, included things that are being part of the role now that were not previously part of this role. Can we talk about appropriate compensation for the new tasks? And I think once we start being able to do that, we're going to be crossing the border from wellness as us telling people that they need to do yoga to actual wellness showing up. If perimenopause, menopause, or another condition in the hormonal space is part of your problem that you're dealing with, menopause.org is a really good place to find people like me who have done the exam and the study to become a Menopause Society certified practitioner. So you go to that page, you go to the little For Women tab, and then you'll find a menopause practitioner near me, and you can search by your zip code. Places online that I think are really, really helpful. Again, I'll shout out Menopause Mandate because they're working to actually improve policies within the workplace and within the government to support women through this time. Postpartum Support International is another good one, as well as Sister to Sister. And some of the things that I would ask for you to speak up about at work is really, communicating your needs to your supervisors, saying, I have to get this mammogram. I'm going. This is what it is. How can we make this work? Setting limits on your work hours and actually sticking to those boundaries, not checking your emails at 9 p.m. and responding at 9 p.m. because that's, something you're doing while the kids are starting to fall asleep. Actually sticking to real true work hour boundaries. And if they do happen to have them because you work for a great employer, utilizing those services, whether it's EAP, employee assistance programs for mental health support, financial support, fitness memberships that are discounted, what have you, go and seek out the things that are available to you so that we can start kind of changing the tide with this. Additionally, some of the other things that you can do to educate yourself, there are a lot of really, really great podcasts and books out now. And if you drive a decent amount, all of these books, ironically, are also on Audible or other places that you can get audiobooks, which is how I pretty much do all my reading outside of patients' charts. And all of these are things that I've read and think have are probably very, very helpful. Couple podcast shout outs. One of the most entertaining ones on the air right now is Dr. Stryker's Inside Information. She is a lovely person and is hysterical. You Are Not Broken with Dr. Kelly Casperson. Additionally, the Menopause Society has a lot of different resources that you can read through or watch videos on. And then Meno Channel is a website that is run by portions of the staff from Menopause Mandate US, who interview experts in the menopause space to talk about different topics. And so those are all really, really great places to look. So talked about what you can do, how you can sort of help the people around you. What can companies and coworkers do? I think we really need to first start with formal training. HR staff, supervisors really need to understand how menopause and other female-specific health issues affect their workers. Not understanding what postpartum depression, anxiety, psychosis are, not understanding what polycystic ovarian syndrome or PMDD do for a patient, endometriosis, chronic pelvic pain, or menopause. It's going to make things a lot easier if you put yourself in a position to understand what your staff, your employees, and your coworkers are telling you. And so I think we need to teach about it more. I think we need to form some formal policies within the workplace that can make having one of these health conditions go on easier to stay in the workforce with. Flexibility in remote versus hybrid scheduling, allowing control over some of the work environment, whether that's a really, really sweaty polyester uniform or allowing control of the thermostat. I think can be small changes. Family leave, perimenopausal, menopausal leave time built in instead of patients needing to take FMLA and or just leave the workforce altogether. Oh no, we're losing my things. Okay. And adding in separate coverage for specialty women's healthcare outside of just saying, yes, this is the healthcare, insurance that we provide as employer, really seeking out specialty care for patients as well. And if you need a little bit of a tip of how to add some protocols to your workplace, you can go to menopausemandateus.com and look at what some of those workplace policies and protocols are and see how you can implement them yourself. And I believe that is all I have to say. Thank you for coming. If you have questions, I heard we're going to talk now a little bit, but you can find me on the World Wide Web as well as at my email and our social. And if you're interested in seeing me, this is our phone number to my office. That's what I
Thank
got.
you so much, Dr. Fiffick. This is amazing. We had a lot of people compliment while you were talking that this is such a helpful topic. Um, and we appreciate how well you know all of your information. And so we do actually have a few questions. One of
And
them is, can you talk a little bit about cycle syncing?
yeah, so there's not a lot of good data to support the fact that that is a true phenomenon. Ironically, we have all grown up with that being told to us. But the fact that a cycle is about 28 days long when it's being textbook, and the fact that we have, 52 weeks in a year, the math just maths in a way that sometimes it's going to look like that. But as far as the data has shown so far, it's not technically a real thing. I will argue there's probably some data out there that we've never collected about pheromones and other signaling that some of our hormones do. But yeah, currently that's what I got.
And
No,
then Dr. Fiffick, we have a comment that this is so amazing. Thank you, Dr. Fiffick, for presenting this. I have several friends and family members that need to listen to this. And so they did ask if we'll be recording, and we are recording, and we can send it out as well. So.
You can save it and share it with everyone.
Yes, this will be posted on our YouTube page, BBB Cleveland's YouTube page, but I can also send you all an email afterwards with the link to it, especially because I know a bunch of the slides that were in the presentation are very helpful to refer back to. And then they
I
also
figured
have,
all the ones with resources are going to get screenshot. So
yep. And then that also has all of her information on it too, Dr. Fiffick's information.
And then any more questions, Katie?
I don't have any more
I think
questions,
that's it too.
but I think, yeah.
I'm here if anyone needs one.
No, this is so important. And I think I had some questions before and you answered them all in the presentation. And just being a woman, I think it's really, really important to understand like how to support other women in the workplace. So,
Yeah. I think it's difficult too because as a somewhat younger menopause expert, sometimes I take a little bit of flack for not being so much in the like obstetric space. Um, it's the same problem though, right? Like if we don't take care of women when they are kind of in that sandwich generation and that time frame of their health changing really drastically, and have support for just that woman in that moment, we're not going to get to the point where we have policies and help for things like postpartum depression or parental leave or et cetera, et cetera, et cetera. Because if you take that sort of reproductive component out, realistically, we're looking at the exact same issues that we do not support women very well. And while I 1,000% applaud the BBB for having this conversation, it's a weird conversation to have, right? Like having a wellness week that isn't just like at the hospital. It's always like pizza and like petting dogs and like yoga classes, which is it's fine, but it's not, in my opinion, real wellness. Real wellness is if we're supporting each other, supporting our colleagues and our coworkers and employees, and like actually improving outcomes. So I'm so tickled that you guys even let me come and blabber on like this. So
oh no,
Of
you were
course.
fabulous. We got a lot of great feedback already, and the webinar wasn't even over. So we
Yeah,
appreciate you.
exactly. A lot of great feedback while you were still presenting. Um,
perfect.
we actually do have one more question. What are ways, so you had talked about in the presentation about osteoporosis and kind of by the time that we know that your bones are weaker, it's already a problem. So what would you say are good preventative measures?
Yeah, so this is kind of where the normal conversations with it are behind the times. Ironically, all the things that you've heard of, calcium, vitamin D, weightlifting, blah, 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 like maintaining a healthy weight and not smoking, not drinking alcohol, not chugging an entire pot of coffee twice a day. They're fine and they're good, but by the time you're about 30 to 35 years old, you have completely maxed out the bone density that you're going to live with. So, doing those things is only helpful to build bone when you have not stopped building bone density. After that time, the only thing it's going to help do is not lose more. So, one of the things that is really, really important is if you are one of the younger listeners on this call, is to go out and do those things. Make sure you're getting enough calcium. Make sure you're getting enough vitamin D. No, nobody gets it from the sun unless you're a lifeguard. And after the age of 40, sitting outside without any sunscreen on and claiming that you're getting your vitamin D actually isn't happening because you are no longer converting it from your skin and you're just going to get skin cancer that way. So you really, really have to work at it. One of the things that can be very, very proactive is if you're in that sort of perimenopause timeframe or early menopause timeframe, is going and speaking to somebody who's on that menopause.org website and is a listed clinician, because most other clinicians are probably going to follow that USPSTF guideline that says, yeah, we don't order them until they're 65. Okay, well, has she ever, met any of this criteria or is related to somebody who met this criteria before? Chances are every single person has one grandmother or one aunt that has a hip fracture or a history of osteopenia, osteoporosis. boom, check. You just bought yourself a bone scan.
Cassandra, I unmuted you if you have a question.
Yeah, say I did send a question through the little thingamabob. I don't know where it went from there. But I have a habit of being a hypochondriac. And so, what are things to keep an eye out that are concerning that aren't, going to send you down a spiral of like, oh, I need to actually be documenting my period to make sure that it's not fluctuating? Because that's the kind of crazy spiral that I'll be going down.
I love a period tracker app because it really is good information for people that obsess over it like I do. It realistically is anything that is super scary that would make you want to call a doctor in the first place is things that I need to know about. Do you feel like you're having heart racing, skipping, etc.? Are you getting dizzy and you don't like really know why? Are you having, cognitive difficulties, which I'll be honest, probably about 50% of the cases that I see of people that claim brain fog in menopause, it's mainly because they're not sleeping due to hot flashes, night sweats, or the insomnia that is associated with those things. So if you're having any major, what seems like neurological, cardiovascular, pulmonary type thing, I'm going to want to know. I will go back and say the I'm a hypochondriac thing. You can get rid of that from your vocabulary for all I'm concerned, because if you go into the space of trying to pursue help for a problem, kind of already downplaying the real symptoms and experience that you're having in a healthcare system in which women are more likely to get dismissed for their symptoms, misdiagnosed for heart attacks and strokes, et cetera, you're going to be setting yourself up for an even bigger failure than we're already giving you. And so I think you have legitimate symptoms, document them. Bring me your app, bring me the trackers, show me your spreadsheets. I love data, and it really does help the clinicians who care understand what's going on. So, while some people might get weirded out if you show up with a notebook full of stuff, like honestly, I like it because it helps me pick up subtleties or weird patterns. And so there's nothing that I think, if you think it's weird, tell me about it.
And then I do have one more question. Someone asked, is a lot of this genetic?
Yeah, so there is a lot about perimenopause and menopause that is at least familial related. We're not confident about the genetic part yet and probably won't be until after I'm gone. But there is a lot to be said about if you have older sisters, older aunts, mom, grandma, that can give you information about what their experience is like, that yours may be very similar. The natural ages of menopause are anywhere from about 45 years old to about 55 years old. So if you kind of throw the hedge in there of perimenopause can start in your mid to early 30s and really work its way towards that normal phase of menopause. Ironically, though, we do call menopause that's between ages 40 and 45 early menopause, and then menopause that happens before 40 is called premature ovarian insufficiency. And so the kind of understanding that your sister, your mom, etc., like experienced XYZ thing. You need to nitpick it a little bit and clarify, okay, well, mom, you said you were in menopause at 52, but were you still having periods? Oh, you were still having periods until you were 56. So you weren't menopausal until you were 56, but you had a heck of a perimenopause. And knowing that will help us understand what is likely for you to happen, even if I can't throw, the genetic mutation at it from the lab.
Well, we
Awesome.
appreciate this so very much. Like we said, we've gotten many compliments already. So I just want to do a huge shout out to you, Dr. Alexa Fiffick. You have been great today, and she's clearly around if anybody, wants to schedule an appointment or ask more questions, you can contact her. And then, like I said, this webinar is going to be recorded and it'll be posted to our YouTube page in case you want to refer back to it. And I just wanted to say, as a final shout out for our Wellness Week, thank you to everybody who attended. This is our first one, but not our last. And thank you to all of our accredited businesses.
Awesome. Thank you for having me.
Thank you,
Thank
everyone.
you. Have a good rest of your day.